And we'll make sure that the recording is started. Okay. All right. Hello. Good afternoon, everyone, and Happy New Year to those of you that I haven't greeted yet today. I'm Brenna Rabel, the Technical Director of Battelle's Partnership for Quality Measurement, and I am so happy to welcome you all to this year's Rulemaking Measure review for the PAC LTC Recommendation Group. First, I wanted to just extend my very sincere thanks to each of you for volunteering your time and expertise to be here, especially those of you who signed in bright and early today to also join our roundtable discussion this morning. Your commitment to this process always astounds us and is so crucial. It makes this work possible. As I think you all know, this past year has been an atypical one, particularly with the government shutdown that impacted the MUC list publication timeline. And because of that, sort of across the board, this year's meeting will look a little bit different than it has in the past. In addition, we have some late-breaking updates from CMS about the advanced care planning measure that we're reviewing today that will also impact the structure of our meeting. So the most important thing from our perspective is that we are all here today ready to continue the very important work of reviewing and recommending the measures that will drive quality in U.S. healthcare. Your contributions, as always, directly shape the standards that improve care for patients across the country. So thank you again. And I do want to just turn it over to Dr. Schreiber to give that update on voting for the advanced care planning measure.
Great, thank you. So first of all, good afternoon. Some of you may have been on meetings over the past several days or on the roundtable this morning. Thank you for all of your participation. For those of you who are just joining, welcome. It's nice to see everyone. And we're very excited about these meetings. As always, these are wonderful opportunities to hear from external stakeholders, which helps inform CMS policymaking. As all of you know, today we're talking about post-acute care, and we really didn't have a lot of measures to bring forward, but we do want to discuss one measure around advanced care planning. Advanced care planning obviously is an important conversation for providers to be having with patients about what their wishes are for end-of-life care. We are not looking for decisions one way or another from patients, but we want to ensure that those conversations are being had and documented so that patients' wishes can be met. The advanced care planning measures, which will be discussed in just a moment, are being considered for hospital programs at this time. But the question before you is, do measures such as this belong in post-acute care settings? We recognize the measures that they're as currently written would have to be reconfigured, for example, for a post-acute care setting. So we're not asking you necessarily to vote on should these measures as currently written be used in post-acute care, because we already recognize we would have to reshape them for post-acute care. But the broader conversation is, are these conversations and our measures like this something that belong in post-acute care settings? With that, I want to do my traditional thank yous. Thank you to Battelle, really, for a tremendous job in organizing these meetings. Thank you to CMS, our partner federal organizations, the measure developers, and others on the calls. There's a lot of work that goes on behind the scenes for these kinds of meetings, so a thanks to all of them. But most importantly, to all of you, joining through the Partnership for Quality Measurement, being part of the pre-rulemaking cycles. This really helps inform better policy, which hopefully leads to better health and health care for all Americans. So thank you for your participation. And with that, I will turn it back to you, Battelle.
Michelle. I do just want to make sure it's super clear to everybody. So I think some folks joined the call today expecting to vote on the advanced care planning measure. So just to make sure everybody knows, we are still talking about that measure today. but it's no longer being considered right now as it's currently specified for the program. So as Dr. Schreiber said, even though there won't be a vote, what we're really trying to get at here is whether this would be valuable in PAC LTC settings, and get your feedback on that. Does that sound right to you, Dr. Schreiber? Okay. All right, then let's go ahead and jump here to housekeeping. So to make today's discussion as productive and efficient as possible, as always, we just ask that you keep yourself on mute throughout the discussion until you're ready to make a comment. You can use the hand raise feature to let the facilitator know that you'd like to chime in. And once you're called on, you can go ahead and unmute yourself to speak. Once you've finished your comment, you can lower your hand and remute yourself. That just helps us keep track of our queue of commenters and to minimize distracting background noise. If possible, do your best to stay on video throughout at least the discussion portion of the meeting. It just helps foster community building and discussion. And then finally, feel free to use the chat feature in Zoom to communicate with Patel staff. If you're having any technical issues with Zoom itself, definitely let us know via email at pqmsupport@patel.org. We have folks that are actively monitoring that line, so we should be able to troubleshoot any issues you have relatively quickly. Next slide, please. So we have a bit to discuss today, and just to make sure that we're staying as kind of streamlined and focused as we can, we just kindly ask that you please keep your discussion points and questions to issues specific to the measure at hand. Throughout the meeting, we ask overall that you adhere to our community guidance for these meetings, which means, of course, respecting all the voices on the line today, staying as engaged as you can, actively participating when called on, keeping your comments concise and focused, and being really respectful of everyone's time today and allowing others the opportunity to contribute. We also ask that folks be generous when sharing your expertise and experience. And then, of course, as always, take the opportunity to listen and learn from the others that are here with you. Next slide, please. I think everybody here knows we live in a pretty acronym-rich environment. So we just provided a list of acronyms that we think you're most likely to encounter during this meeting. Feel free to hang on to this slide for later if you need to reference it. Next slide. So a few Patel intros you've already heard from me. You're also going to hear from Dr. Meredith Eastman, Kate Buchanan, and Dr. Lydia Stewart-Arts. Just to give you an overview of the process today, Meredith is going to be the one that's actually facilitating our measure discussion. And then on the CMS side, you already heard from Dr. Schreiber, and I just wanted to acknowledge the other folks at CMS that help support this work: Helen Dollar-Maples, Nidhi Singh Shah, Charvan, and Mel Gross, and then, of course, the many CMS medical officers and leads that contributed to getting us ready for today. And with that, let's go to the next slide, and I will turn things over to Kate.
Thanks so much, Brenna. So if we move on to our next slide, so we want to thank all of our committee members for being on here today. And our advisory group members will be really important for providing and setting the stage for the conversation that the recommendation group will have, and we're incredibly grateful for your time. We are conducting roll call for the recommendation group. But it does not mean at all that we don't want our advisory group members raising their hands and speaking up. We just ask that you introduce yourself prior to the statement. We won't need to do conflicts of interest for this because we are not voting today, but I am going to ask, as I do roll call, for you to introduce yourself and any organization that you are associated with that. Afterwards, I'll turn it over to our co-chairs to provide some opening comments. And I'm going to apologize ahead of time for any mispronunciation. Robert Aceta? Okay. Oh, Robert, you're on. I just maybe having some trouble unmuting. So if you're able to reconnect, let us know. Donna Berdotsky.
Hi, I'm Donna Bednarski. I am a nurse practitioner in Detroit, and I represent the American Nephrology Nurses Association.
Thank you. Lynn Benke.
Good afternoon. I'm Lynn Benke. I'm from Taos City, Michigan, another Michigander, a nurse practitioner in a very rural area. And I'm pleased to be here. And I represent both the American Heart Association and Women Heart, the National Association of Women with Heart and at Risk for Heart Disease.
Thank you, Lynn. Jeremy Benton? Okay. Jennifer Brockman?
Good afternoon, everybody. Jen Brockman. I'm Chief Clinical Program Officer with the Compass Healthcare Collaborative in Iowa.
Thank you. Laura Burrows? Melissa Butler?
Hi, Melissa Butler. I am from West Virginia. I am representing the patient and caregiver view, but I do work for Amedisys Home Health and Hospice.
Thank you, Melissa. April Coxon?
Hello, my name is April Coxon. I'm a registered nurse, and I am the Executive Vice President at Healing Hands Healthcare. We are home health, hospice, palliative care, and guide program service lines. And looking forward to today's call. Thank you.
Thank you. Rohit Das?
I'm Rohit Das. I am a neurologist with VA Portland Healthcare System. I'm representing myself, not my organization.
Thank you. Mary Ellen D. Bartolin-Bin? Sorry.
Hi, good afternoon. I'm Mary Ellen DeBartolabin, and I'm the National Director of Quality for Encompass Health. It's good to see everyone this afternoon.
Thank you, Mary Ellen. Jody Iargor?
Hi, Jody Eager from Leading Age.
Thank you. Danielle Gratzky?
I'm Danielle Gratzky, and I'm the Quality Risk Manager at Madonna Rehabilitation Hospital, and I am representing them.
Thank you. Patricia Henwood?
Hi there, Tricia Henwood, Executive Vice President, Chief Clinical Officer of the Jefferson Health System, 32 Hospital System, Pennsylvania, New Jersey. I'm an emergency medicine physician.
Thank you. Troy Hillman?
Hello, everyone. Troy Hillman, Director of Quality and Health Policy at the American Medical Rehabilitation Providers Association, or AMRPA, representing roughly 800 IRF member hospitals.
Thank you. Laura Hoffman?
Hello, Laura Hoffman, Vice President of Nursing and of Clinical and Nursing Regulatory Services for Leading Age Washington. Thanks.
Thank you. Sarah Hewling?
Hi, Sarah Hewling here, self-proclaimed rural renegade. Go Mountaineers there, Melissa, born in Morgantown, but I'm up here in Forks, Washington. I represent myself as a rural health advocate, and what else? Oh, I am an elected commissioner at our public hospital district out here. And again, I only represent myself. Thanks.
Thank you. Andrew Jakubik? Okay. Sabina Khan?
Hi, my name is Shabina Khan, and I'm a patient and a caregiver advocator. I'm a community at Chicago, and I community care, and I'm supporting Rainmakers right now and other community vendors, and it's great to be here. Always a pleasure. Thank you.
Thank you, Shabina. Annette Kaiser?
Hi, thanks for having me. Annette Kaiser, a registered nurse. I have 40 years experience in the hospice and palliative care industry, representing NPHI, which is the National Partnership for Healthcare and Hospice Innovation, with over 100 hospices across the country, and also Teleos Collaborative Network, working with organizations across the country as well.
Thank you, Annette. And I believe Kate Lally was unable to attend. Kathy Larza?
I'm Kathy Larza. I'm the Assistant Director for the Kentucky Division of Developmental and Intellectual Disabilities. And part of my responsibilities are the performance measure collection and the quality improvement work for our 1915C waivers.
Thank you. Stephen Littlehill?
Littlehale. Hi, Steve Littlehale. I am the Chief Innovation Officer at Zimet Healthcare. I'm a registered nurse and a clinical nurse specialist in gerontology. Previously, I've successfully brought 2 measures through the NQF process related to hospital utilization in nursing homes. This was in collaboration with the American Healthcare Association and Brown University. Glad to be here. Thank you.
Thank you, Steve. Vicky Parika.
Yeah, hi, this is Vicky Parikh. I'm a primary care provider with public health specialty, and I'm representing myself here. I do work with MedStar, and I'm Vice President of Population Health and Value-Based Care. So nice to be here. Thank you.
Pamela Roberts.
Yeah, I'm Executive Director at Cedars-Sinai Medical Center in Los Angeles, California, and also on the American Occupational Therapy Quality Committee.
Thank you. And I know that Anthony had some personal issues this morning and was calling in. I don't think he's on yet, but we'll keep an eye out for him. Kurtaleen Syed.
Hi, my name is Kuratulan Syed. I go by Annie, as that's easier to say. I'm a geriatrician based at Atlanta, VA, and I'm representing myself.
Thank you. Melanie Wascom.
Hi, I am also representing myself, Melanie Wascom. I'm the Director of Clinical Compliance for LTC Group, now Optum.
Thank you. Chad Wards.
I'm Chad Wers. I am a consultant pharmacist by background and the chief executive at the American Society of Consultant Pharmacists. We represent pharmacists and pharmacies that are in the long-term care, older adult, and medically complex space.
And I believe, Robert, you have been able to connect to audio if you wouldn't mind introducing yourself. No. Doesn't seem to be working, Robert. I would maybe sign in and sign out because we're on our end, you're showing unmuted, but there seems to be something happening. Well, thank you all so much. Really appreciate it. I am now going to turn it over to our co-chairs, Janice Tupty and Carol Seibert, to make some opening comments. Janice, let's start with you.
Hi, thank you for all being here today. It's nice that we have a number of individuals, both from the advisory group and recommendation group from CMS and other institutions. I am excited to hear about what people will talk about today, their thoughts on the advanced care planning. I personally think this is very important for all people over 18, as you never know when an acute care event might happen, and for older individuals as well, and to better prepare family and care partners for what might come. And often they actually don't realize that advanced care plans have already been put in place. I'm from Seattle, Washington, and have been active in with Partnership for Quality Measurement and Measurement actually since 2015. So I'd like to pass it over to Carol. Thank you.
Thanks, Janice. I'm Carol Seibert. I'm an occupational therapist, and I am primarily a clinician. I have worked with older adults in their homes for 37 years in home health, in home-based primary care, in aging in place consultation, and in private practice. And I've been practicing long enough that I remember at the first home health agency where I worked when we were all gathered into a big room to learn more about the Patient Self-Determination Act that was passed in 1990. So it's interesting to look at this measure from the perspective of how many years have passed since that law has come and how far we've come and also how far we have not come. So I represent myself. I currently work in a home-based primary care that's a combination or sponsored by an academic medical center and an FQHC. And I'm also in private practice. So I'm looking forward to our discussion and the insights that we have to share with CMS.
Thank you, Thank you very much, Carol. I appreciate it. We're actually going to skip to slide 14. I'm going to hand it off to my colleague, Meredith.
Great. Thanks so much. And in case I haven't
met you yet, my name is Meredith Eastman. I am the Pre-Rulemaking Measure Review and Measure Set Review Task Lead at Battelle. Before we get into talking about the Advanced Care Planning Measure, there are just a couple of things I wanted to go over that we're going to share about public comments and a literature review that Battelle conducted on closing gaps of care. So we can move to the next slide. So we have a written public comment opportunity on our website once the MUC list is published. This year, our public comment period for written comments was December 16th through January 6th. And during that period, we received a total of 600 comments in writing across all measures on the 2025 MUC list. And we've put a link in the chat of a compilation of all comments we've received, not just the written public comment, but also comments we received spoken aloud at a listening session on January 8th. And we can move to the next slide. So specific to the Advanced Care Planning Measure in the PAC LTC setting, we received a total of 110 comments. 10 of those were spoken comments received during the listening session on January 8th, and then we received 100 written comments in writing during our written public comment period. So again, we're sharing a link in the chat if you want to look at those comments in detail. We will do a little bit of a summarizing of what we heard from the public before we open it up for you all to discuss. And we can move to the next slide. So Battelle has also conducted a brief literature review of peer-reviewed literature and federal agency websites to identify how measure topics and conditions might differ by factors such as age, geography, dual Medicare and Medicaid eligibility, insurance status, and language. So we'll be summarizing what we've found in the literature about advanced care planning before we dive into the discussion. Just wanted to note that closing gaps of care is not a formal primer evaluation criterion, but we do hope that you'll reflect on the information provided as you provide feedback on how each measure through use in a Medicare quality program may contribute to closing or widening gaps of care for various population groups. We can move to the next slide. So before we dive in, we talked about this a little bit at the education meeting, but just as a refresher, we're going to structure this meeting a little differently because we do have advisory group members on in addition to recommendation group members. So what we're going to do is show an introductory slide with some basic characteristics about the Advanced Care Planning Measure. I will then turn it to a CMS medical officer to provide some additional context on CMS's interest in expanding this measure in PAC LTC settings. Then I'll summarize what we heard from public comments, and then we'll review closing gaps of care literature review findings. Then I will turn it to our advisory group members first, hoping you all will help us identify key priorities, topics for discussion, what you really want the recommendation group to focus on. We'll then open it up for our patient participants, hoping to hear from them how this measure reflects their needs as patients, what their perspectives on the topic might be. And then we'll open it up to all recommendation group members to participate in the discussion, having heard from the advisory group and the patient perspectives, continuing the conversation to drill down into, topics that have been prioritized for discussion. We did put a cheat sheet to that flow in the chat. So do feel free to get a refresher on that as we get started. A reminder, we will not be voting. So this will be a bit more of a free-flowing discussion. So we can move on to the next slide. Great. So Our measure under discussion today is MUC 2025-020, Advanced Care Planning. It is the percentage of patients aged 18 years and older at the start of the measurement period with one or more inpatient encounters during the measurement period who have an advanced care planning document or documentation of an advanced care planning discussion, resulting in a documented decision in the electronic health record by the time of hospital discharge for at least one hospital encounter during the measurement period. So this is a process measure, and it's assessed at the facility level. It is not endorsed by the consensus-based entity, and it has not been submitted. It is stewarded by CMS, and we can move to the next slide. So this is, again, we're discussing it for a number of PAC LTC programs. Again, we're interested in hearing your thoughts on, the suitability of this measure in this setting. So with that brief overview, I will turn it over to CMS for some additional background and context on this measure. And am I turning to Dr. Ron Klein?
I'm going to start with just a few comments, Meredith,
Great.
and then turn to Ron, who's sitting right next to me, actually.
Great.
So again, thank you all for the conversation. We knew if we brought you the hospital measure that all of you being astute in quality measures would say, post-acute care doesn't do electronic clinical quality measures. These haven't been specified at the level of the post-acute care facilities, and you would rightly vote it down. So we recognize the challenges for post-acute care when it comes to digital measures and the fact that these measures would have to be somehow changed, morphed, and respecified for a post-acute care setting, which is why we want to have the conversation with all of you today, so that you can provide us input. Are the post-acute settings the correct places for this? Who would have the conversations? Should the individual facility be held attributable to these? How would it best be done if it is not done through an ECQM? How would it best be operationalized in a post-acute care setting? How would you envision that being done? And that's the kind of conversation we are looking for from all of you today. Also, did we miss something? How would you change the measure? How would you either expand it or make it different or have different exceptions than perhaps what is being included on the hospital setting? Is it appropriate at 18, for example? So those are the kind of questions that we hope we can get into today. And with that, I'm going to turn the conversation to Dr. Ron Klein, who's going to lead it for CMS. He is a pediatric hematologist, oncologist, and has a lot of experience with cancer patients. And he is one of the people who is really very much driving advanced care planning. So give us a moment because we have to change audios here, and Ron will be.
Good afternoon, everyone. I can even say good afternoon to the Californians because it's afternoon in California. So it's really a pleasure to be with you. As Michelle said, we review this as a very, very important measure in CMS. And really, even though we can't vote on it in the PAC setting, we are anxious to hear your thoughts around this measure. A couple things just to sort of start out with. This measure, many of you may be familiar with NCQA measure on this topic, and there are a couple of differences here, and at least the way it's specified for the inpatient setting, and the way two of the differences are one, it includes all ages, so it starts at age 18, and I'll just digress slightly and say that I think that the goal in having it include age 18 sort of twofold. One, almost threefold. One is to sort of normalize this as a conversation to be had, with your caregiver. And the second is to have a normalize as a conversation to have with your loved one, because by designating healthcare proxy, you who have had that conversation with your proxy, and perhaps you've had a conversation with about what exactly what exactly you would want. So really the idea here is to normalize this as a conversation that we have with people, not just if they're 65, but if they're 18 or 20. And I think as has been pointed out in some of the conversations we've had, if you are, for us, in an inpatient setting, but in this case, if you're in a post-acute care setting and you're 30 years old, you're not a normal 30-year-old. So you're in a higher risk group just to begin with. So having this is an important conversation. We had our hospital primer group meeting yesterday, and one of the patient advocates was talking about her experience where basically she'd never had the advanced care conversation with her husband, and because she never thought she had to, and as they were intubating her, she couldn't talk about it with her husband, and her husband didn't know what to do in terms of her wishes. So I bring that up as a statement that life is unpredictable. None of us know when we're going to be in a difficult medical situation. None of us know when we're going to be unable to speak for ourselves in terms of what we would want for ourselves. And so having this as being a part of a normal conversation you have with an adult patient is important. I think the other thing, and I was part of the TEP that reviewed this, and this is sort of an aha moment that we had, is that even those of us who are medical folks, if we looked at a MOLST or POST form, we'd have a hard time saying, well, when do I want compressions? When do I want intubation? When do I not want intubation? When do I want meds? And that's difficult for a clinician and probably near impossible for a non-medical person. And so our aha moment was really that for the purposes of the numerator, designating a healthcare proxy counts as satisfying the measure. So the idea being that you may not know if you want intubation or compressions or meds, but hopefully most of us in our families have someone that we trust, if we couldn't speak for ourselves, who we would trust to speak for us. I was going to say, the last thing I was going to say is the way this is different from NCQA, the NCQA measure, as I understand it, and perhaps I'm wrong, but we've designated the numerator in this measure as having an outcome. We were just having this conversation of whether this is a process measure or an outcome measure, because there has to be an outcome to the conversation. So it's not sufficient to simply code, I had a conversation with a patient about ACP without specifying anything. That does not meet the numerator. The numerator can be, I had the conversation and nothing is different, or we had the conversation and everything, the patient wants everything done, but there has to be some specified outcome to that conversation. So that is a different way that this measure is different from perhaps other measures. And then the last thing I'll say, and I could talk about this for hours, excuse me, is that there are a lot of state laws that exist right now in terms of next of kin, so the question might be, well, why do you even need this? We have state laws to specify this. And the problem comes up is sometimes, unfortunately, families are estranged and or they're not estranged, but they just haven't had the conversation with mom about, Mom, what do you really want if this happens? And sometimes you'll have siblings who are the ones who are, or children who are the next ones who are designated in the line of succession, if you will, in terms of state laws designating next of kin, and the siblings disagree as to what should be done. So these are just a lot of ways of basically saying that CMS views advanced care planning really at all levels of care as vital, as critical, that it's best care for a patient to articulate what their wishes are during their healthcare journey. And this is something that we'd like to move forward with over time. So with that, I'll stop talking and allow the conversation to begin.
Great. Thank you so much, Dr. Klein. And before we open it up for discussion, I did just want to...
You have to put your... Wait, I can put mine on. That's fine. Hold on.
So before we open it up for discussion, I did just want to summarize what we heard from the public comments. Some of these comments will echo, some of the commentary that's being provided in the chat, some of the commentary that Dr. Klein just provided, but comments in support, actually, I should start by saying we received 100 written comments on the measure and 10 spoken public comments. Comments in support of the measure noted that any opportunity to interact and assess patients' end-of-life wishes should be encouraged. Comments stated that ACP is critically important for helping individuals articulate and document their values and preferences as they age to ensure that the care they receive, including end-of-life care, is aligned with what matters to them. Furthermore, improving data collection and reporting about advanced care planning can enhance the quality of care, particularly for older adults and individuals with serious illness. Comments noted that ACP is applicable early and frequently over the course of serious, complex, and chronic conditions, and not restricted to end-of-life focused advanced directives. And care planning conversations should be systematized in every care setting as a standard aspect of quality care delivery and accountability. Lastly, some comments noted that addressing advanced care planning can save patient and facility resources, but also help avoid inflicting unnecessary and futile pain and discomfort at the end of life. There were some concerns noted about this measure, specifically a request for clarification on what documented decision means. Sometimes ACP conversations often result in no decision or a decision to defer. And so just some clarification on how that might be captured if no decision essentially is the decision and how that gets documented as it does reflect patient autonomy. There was a comment indicating that there's the potential for ACP to be addressed excessively during patient stays, which may lead to patient fatigue or confusion. So that was just one consideration there. And there was some concern about ACP interoperability or portability across settings. And another comment that the measure focuses on documentation, but not necessarily the quality of ACP conversations. So wanting to ensure that there's training for folks on how to facilitate ACP discussions that align with patient goals to support, meeting the numerator of this measure. Lastly, there were a couple of comments specific to use of this measure in the inpatient rehabilitation facility. So those of you speaking from that perspective, your comments on this are welcome when we open it up. Where patients who are experiencing a short stay transfer may not be in the setting long enough for an ACP discussion to occur, and wondering if that situation should be considered for denominator exclusions. So that's what we heard in summary in terms of public comments, and we can move to the next slide and I'll review our closing gaps of care considerations. So in terms of age, our literature review found that advanced care planning in older populations may increase potentially burdensome care at end of life. Let's see, I think that might be a miswording, but the important part is that ACP must align with the patient's true preferences. In terms of geography, ACP initiatives are often sponsored by urban or suburban-based healthcare institutions, whereas rural populations are less likely to have access to ACP discussions facilitated by a healthcare practitioner. And in terms of dual Medicare and Medicaid eligibility, the literature found that care and advanced care planning is typically fragmented for patients who are dually eligible for Medicare and Medicaid because they are administered separately and cover different services. There are some integrated models, but only a small fraction of patients are currently enrolled in those models. And I think we have one more slide on this. Great. So patients with Medicare insurance are more likely than those with non-Medicare insurance to have advanced care planning documentation in the EHR preoperatively. Again, that's a different setting than what we're talking about here today, but just for your awareness. And then lastly, patients with limited English proficiency experience barriers in end-of-life decision-making and care planning. These barriers include prolonged ICU stays, death in the ICU, increased and aggressive interventions at end of life, increased use of restraints, lower rates of comfort measures only, and do not resuscitate orders despite imminent death. So that's what we found in the literature on this topic. And so I think we can go back to the measure overview slide. And I'd love to open it up to our advisory group members who would like to just kind of set the priority, set the tone for this conversation. And Cheryl, I see that you have your hand up.
I just jumped right in, didn't I? So Cheryl Phillips, geriatric physician, I'm now retired, but post-acute long-term care, and I'm speaking as an individual. And I really love the context that was framed and agree with all the comments. I want to highlight 3 quick points. One is who has the advanced care planning conversation is critical in a post-acute. When it was made a regulatory requirement in some states, I witnessed business people doing enrollment and then handing them a POLST form and having them fill it out and then calling that an advanced care planning discussion. It's not. So again, in addition to the training that we talked about, the who is really important. Secondly, in the context, particularly for post-acute and long-term care patients, the choices that they may be faced with, they don't have a context of what they mean. And I know that you've made reference in the preceding comments. I think that all ACP discussions should start with what matters, whether it's in the model of the patient priorities care system or in the 4Ms, what matters, but understanding from the individual their value and context, even before you start checking the box about CPR, hospitalization, non-hospitalization, et cetera. And then the last thing I just wanted to add as a former PACE chief medical officer, advanced care planning is a CMS requirement for PACE programs, and it's built into the care planning. So it is a doable, accessible, and reasonable strategy for high-risk vulnerable populations over time. Thank you.
Great comments to start us off, Cheryl. Thank you so much. I'm going to turn to Christine. I saw that you put a comment in the chat. I don't know if you want to raise that here, if you want to start with something new. Up to you.
Just for anyone that didn't read the chat. Oh, sorry. Also, probably catching something out here. So I've had my last rites read to me multiple times. First time at the age of 5. I was not included in any of these conversations at all until I turned 18. In my 20s was when I switched over. I was a Medicare patient at 27 years old, and that's when I was doing the paperwork again. At that time, I didn't get any help. It was paperwork that I sat down by myself, read through, trying to figure things out. And since then have redone the paperwork as well, right? Just under my own thoughts and no guidance though from anyone really on how to do that, even despite being in the Medicare, now Medicaid system. So I guess one of my thoughts was the kids, right? I mean, obviously at 14 years old, at 5, maybe I didn't understand it, but at 14 years old, I did know what was happening. And so really, how do you, when you're not 18 years old and you're not considered that adult, how do we still honor their wishes, right? And hear their perspective besides just saying, you're young and you just don't know. So I guess that's all I have to say in that respect. Also, one other thing was I did donate my body and one of my organs somewhere else. I filled out the paperwork, signed all of the things with the institutions. I don't even know how that's going to be implemented if something happens to me. And so in that planning, how is it carried out as well? And that's it. I'll stop. Thank you.
Thank you so much, Christine, for centering us on your story. Thank you for sharing that. And I hope that you're able to fight off whatever cold is creeping up. Thank you for being here today. Karen.
Hi, good afternoon, everybody. My name is Karen Charles. I've been in the field for over 30 years, 20 of which I've spent in long-term care, skilled nursing facilities, also specialty care, skilled nursing facilities for individuals with HIV and AIDS. So I've seen the spectrum of individuals from young to a geriatric age population. And advanced care, I'm also in New York State. So advanced care planning is a really big issue, not issue, but a really big subject here and has been for many, many years. I don't know how many, most and all of those things have been a part of our whole lives for a long time, and also advanced care planning in the nursing home facilities. I will say that one of the issues that we have had, especially in the advanced care planning process, was previously portability. Obviously, there are ways around that. But what happens when an individual has to go from state to state? As we know, CMS has a standard, but then each state may have another standard that may be higher, and then a facility may have a standard that's also higher. And then what is the bar? We know the bar is supposed to be, the state, but you're also held to a higher standard if your standard is higher than what is put out by the governing body. And also from one state to another, it's also different. So say something happened to me, I happen to have an advanced directive with me when I went to another state. What happens then? What happens if a state is not connected to like a Rio or not connected to the system? We're very segmented in a lot of ways. And I feel like I'm a big proponent of advanced care planning, especially when it's done in the conversation. I think many years ago, it was a very big taboo. I'm not saying that it's less of a taboo, but it's more acceptable now to really speak about care, and not about end of life care, but just care in general. What if something happened to you? What would you like done? Like one of the things that I loved, what that happened, like on the iPhone, I have an iPhone, you can, and I know some Androids, you could put your medical information in and you can have that written and be there with you. So there's a lot of things in advanced care planning that we've only like sort of touched the surface on. But I'm just happy that it's happening. And the more that we bring it to light, the more conversations can be had around it, because it's not just for sick people. It's not just for older people. It's for everyone. And I think as long as we normalize that and it begins to normalize it, it's an easier conversation to have, and that we don't have to really worry about the measures so much. And I hope I'm rambling, so I hope that made sense. That's it.
Oh, that was great. Thank you. And I think your point about normalizing the conversation is probably, part of the intent of this measure, to support, in all settings that this conversation happens. Your comments about kind of portability of the information has been echoed in the chat. And I think, the concern about aligning standards and portability across states is very important to keep in mind. Annie, I believe you are next.
Agree with everyone's comments. I had, especially as we were talking about what matters most in some of the earlier comments. So on advanced care directives, as some of the other speakers said, usually providers are thinking about conversations on do not resuscitate or resuscitate and intubation, and not necessarily what matters to the patient. And if this will be a metric that will be applicable to home care, my understanding is that when skilled home care is ordered, it's usually a registered nurse, social worker, physical therapist, and occupational therapist that go. So maybe the metric may need a little rephrasing as with words of discussion on what matters most, instead of just advanced care planning, which most people assume as conversations related to resuscitation and intubation. The other thing, which it's just a comment, it's nothing that should be a deterrent, but in Atlanta, there was recently news of a lawsuit that happened at a nursing facility where a patient signed DNR, but when the patient coded, the patient had cardiac arrest. The family claimed that the person did not have decisional capacity, and the lawsuit lasted for 5 years, and then there was a settlement. So while it shouldn't be a deterrent to having these conversations, but in reality, like the provider who's filling the DNR assesses decisional capacity informally and has the person sign it. There isn't much formal documentations done, and the family isn't usually the person making those decisions unless there is formal guardianship. But some of these issues do become a little difficult in those settings where afterwards, how do you prove or disprove that a person had decisional capacity at that time? So just one of the barriers. That's it.
Great comments. Thank you. So a little bit about putting what matters to patients up first, to making sure this isn't limited to a checkbox on DNR intubation, and then concerns about determining capacity for decision making. Teresa, I believe you're up next.
Hey everyone, my name is Teresa Schmidt and I'm here today representing the Advancing Excellence in Long-Term Care Collaborative. For those of you who don't know us, we're a forum of multiple stakeholders that come together to take collective action and develop policy recommendations around issues that affect the quality of care and life for individuals receiving post-acute and long-term services and supports. So my comments for Advancing Excellence center on the skilled nursing facility and nursing home side of care. So one of the considerations, of course, and I was very glad to hear that we weren't voting, or that the recommendation committee wasn't voting on measures that hadn't been specified yet. So I definitely support that decision on this call. So as we're thinking about specification for the nursing home setting, definitely thinking about the time that a resident is in place. For very short stay residents with short turnaround times or very quick readmissions, a measure like this wouldn't have time for a quality conversation. And that was definitely a concern that many of our members raised, was the quality of advanced planning conversations being so important. The other element to consider here is, of course, and by the way, I'm echoing comments that others have made both on this call and on the public comment, to enforce how much we, and I agree with them. So no decision should be counted as a decision as a result of the conversation. I was encouraged that choosing a surrogate would also count as a decision. And I think for me, that makes this measure for younger patients and residents a more applicable measure. And that was some of the concerns that our members had raised as well about the age. There may also be some situations when someone comes in the nursing home that doesn't have a surrogate already and may not have the capacity to have a conversation and make a decision. So that scenario should be definitely considered in the specification of this measure when we're talking about who might be excluded. And again, as we think about the nursing home setting, people tend to stay, especially our long stay residents, by definition, for longer periods of time. So the frequency this should occur and be assessed should probably be thought through pretty carefully. One of our members said that anytime a change in condition or a change in status occurred where it was significant, that might be a good point that would trigger a new conversation. And yeah, I think all of those are important things to ensure this doesn't become a checkbox measure and doesn't force people to have conversations that they're not able or ready to have. I may have additional thoughts as we go, but personally, I'd like to say I did research on advanced care planning several years ago and very much support this as a concept, and a concept for the post-acute and long-term care settings where this is a topic that can really save a lot of pain and heartache for residents, patients, families, and financial costs for the healthcare system as well.
Great comments. Thank you so much, Teresa. Dr. Klein, did you want to weigh in?
Just a very, very brief comment. So first of all, thank you so much for all your supportive comments. I'm having such a wonderful time reading the comments, and I was saying as a pediatric oncologist, that point about when a teenager becomes able to make their own decisions is critical in the work that I do. But that would sort of been it's a 2-day conversation. The only thing I want to add, because this has come up a few times now in terms of a certain period of time that a healthcare system would need or a clinician would need before doing an ACP is I think that we need to do a little better than that. And the term I would use that's very common in medicine is triage, right? And we've used that a lot today in some of our other conversations about other healthcare services. Is if you have we don't always know what's going to happen the next minute, right? But if you have someone who's going to surgery the next 2 hours, that might be a life-threatening surgery, then probably at the top of that list should be an ACP conversation. So I guess my only point is that yes, things happen that you're not ready for, and I think one of the conversations that came up in the hospital setting was what do you do if the person doesn't even have capacity from the moment you see them, to make that decision. That's a very important question as well. But I would say that I think that in a setting where time is of the essence because you don't know what's happening or things are changing rapidly, that ACP conversation should be a high priority. So I guess I would say I'm not sure how supportive we would be of having you have 3 days to do this. I think we'd really want to have the clinician say, this person's going to surgery in the next hour. We need to have this conversation.
Hey, thanks for that, Dr. Klein. Claire, over to you.
Thank you. I think those are such important points that Dr. Klein just rose. I'm not in the same camp as Diane Meyer and Sean Morrison in their 2022 article that talked about how ACP doesn't achieve its desired outcomes. However, I think some of the things they mention in that article are important considerations for this group. I don't know if everybody's aware of it. I can, of course, post the link to that review, but it is based in the data that's come out of using ACP in multiple settings, including the nursing home, and whether or not it really resulted in meaningful end-of-life care that aligned. And I think one of the points that I thought was really quite interesting was this idea that you can't really cover all of the scenarios that are going down when the events occur. There's serious illness, and then there's serious illness. And I only say that because I've been there in so many scenarios where intubation actually made sense instead of what we thought because of the scenario we were dealing with. So I think this, from my clinical experience and then reading and understanding this at a deeper level, this idea of goal concurrent care and what is a meaningful life is really critical, even for people who don't have capacity. So we don't want to force, so another hat that I wear is that I'm a bioethicist, and we don't want to force care on people, even if they don't have the capacity to make that decision. If they're not willing to receive that care, we won't chemically force them or physically force them to receive potentially life-saving care even. So how do we honor the human being in front of us? And I think it's by understanding, when are they the happiest? When do they show joy? When do they show pleasure? When are they able to tell us that they're well? And especially in the post-acute care setting, long-term care setting, some of those metrics are even more important. What the nursing staff observe, the aides observe when somebody's at peace and when they're not. If they want blood draws, if we can barely get blood from them, this kind of a give and take is really, I think, critical. So if an ACP measure is adopted, I think it has to include goal concurrent care and a measure of what does a meaningful life look like, even if that is through the gaze and the lens of the caregiver who seems to know the person really well.
Thank you so much, Claire. Those are really important comments. And again, I think, we're hearing a lot of folks wanting to put, what's meaningful to the patients up front, as a priority in this conversation. So I'm going to see if we have any other additional patients who would like to contribute to the conversation. We'd love to hear from you on your perspectives. We've heard from Christine leading the charge here, but are there other patient committee members who would like to weigh in on this measure from their perspective? Shabina, the floor is yours.
Yeah, I just had a question. So there's some hesitance. What happened with my mom? She wasn't aware of this document, but she only told us verbally, hey, if something happens to me, that's it, don't resuscitate and all that. But then we all went on our own ways, and and then there was one of my sibling was home, and he was an administrator, and he kept her on, and the rest four of us didn't want her on the respirator. And so eventually we had to get the doctor involved, and then we all decided, okay, it's time for her to go. But that's one thing, because there's so much hesitance in culture, religion, that they don't take this. And some cultures, they just avoid it the whole way. And then there's other things that you do sign the document when you were in the ER, or you had a so-called procedure done, and they make you sign the initial document and you agree about it. How often would you renew this? Would it be like every 5 years? They also say every 10 years a person changes. Do you renew this and they change their mind after 10 years or 5 years? How often is this going to be revisited, the document of signing this, and make sure everybody's in the same page? And is it going to be updated in Epic every 5 years, 10 years? Is there any documentation on that?
First, thank you, Shabina, for sharing your story and your perspective. I think, Dr. Klein, you had some thoughts on frequency with your triage model. Did you want to reiterate some of those points in terms of timing of updates?
Yeah, I don't think so thank you for your support. I'll say that again. I think the fact that we're talking about how often these ACPs need to be updated means that we all agree that we should have them. So thank you. We're going to take that as a win. I don't know how often they should be updated. I did put something in the chat that I think in some future world, hopefully not very far from now, and already in 10 states, there are digital lock boxes. Because the issue that comes up that has sort of been peripherally raised is that you have a MOLST, you have a POLST, it's sitting on a magnet on your refrigerator. 911 comes and you present to the ER, and the doctor doesn't know what to do. And so having a world where we can access those digitally in a secure way, I think will move this field forward. And once we can get this ACP measure forward, my next goal is going to be to figure out how we can get all the states to do this, because I think that's would be a giant change. But to answer your question directly, no, I don't think we've thought that far ahead as to how often they should occur. I guess it's sort of like a will, I guess, in one sense, right? Is you have your will, and as long as you don't change your will, there's no reason to update it. It's good, but But yes, I mean, the broader statement, and I'm talking in circles, and I apologize for that. The broader question should be, yes, if you have a primary care physician, or you have a physician you have a relationship with, or family members you have a relationship with, this should be an ongoing conversation. Like, I changed my mind. And in terms of the healthcare proxy, you're making, I'm gonna, I had a patient who was I think a 17-year-old young lady with cancer, and who said, I don't want to be intubated. And her mother overruled that. We intubated her, and she survived, went to bone marrow transplant. There's now a 35-year-old young lady with children, and everything. So yes, I think it's always hard to know exactly what you want to do exactly when, which is why I sort of keep coming back to having someone you trust, literally trust with your life, as the person to make those decisions. I'm not sure if I skirted those questions, but I tried to answer them best I could.
Thank you. And just wanted to also just respond to Shabina's comment about kind of cultural sensitivity and cultural differences in approaching these conversations, and how that might play in to measurement. So I think we're about ready to open it up to everybody. But before we do, Christine, I wanted to get back to you. I see you have your hand raised.
Yeah, I just wanted to comment on the reassessment, because I think I'm switching right now from one system to another, and they asked me at a period when I was in an ER. And so I think this does have to be reassessed, right? As I get older, some of my thoughts change, and what I want to happen may change, but I think it's important to also reassess this at a point where people are in a different state, where we don't ask them in an ER like, oh, by the way, we don't have this paperwork on file. You need to fill this out, right? And so I think reassessment every few years, I think especially if you're moving from a childhood or a teenage chronic illness into adulthood, should be reassessed differently than, somebody that's just coming in off the street and has to fill out this form. And so how we take that sensitivity in that issue. So that's it.
Great points. And I'm seeing some folks in the chat talking about sort of rules of thumbs for updates, and when changes in status indicate a time to update. And then Lynn is saying that we need to tattoo our our desires. So I appreciate all these comments. Karen, over to you.
So in terms of the timing, I was wondering, if any thought has been given, obviously maybe, some thought has been given to aligning it, especially if this is a facility-based measure. I'm just going to say specifically for post-acute care skilled nursing facility, aligning this measure with something that already exists with your MDS and your care planning that's required, that has timeframes for advanced care planning initiatives in it, aligning the timeframes with those minimum timeframes in addition to as needed or as necessary, or whatever have you. And I know as needed and necessary, everybody says it, and but sometimes during what we consider, especially in long-term care, after a traumatic event, someone has lost a relative, after somebody has, maybe their husband passed away, their wife passed away, they lost a child, different people's perspective change. So as needed also can have like an example of times when as needed may be applicable, in addition to aligning with those quarterly, those 6-month, those annual review periods, of course, with your admission, and then prior to discharge, before that person may go to the community if they're a short-term stay, or even before someone goes to another setting, like say they're coming from a skilled setting to a lower, quote unquote, lower level of care because they're more able, that decision goes with them. And then they do that. So just if any thought has been given to aligning it with pre-established timelines, in addition to additional examples of when it would be appropriate, instead of just saying 10 years or 15 years or 5 years or, something like that.
Yeah, so incorporating some needed flexibility for more frequent updates, in addition to perhaps a time-based update. Alyssa, you have your hand up.
Yes, hi, thank you, everyone. I'm a physiatrist. I specialize in physical medicine and rehabilitation, and have over 30 years of experience working in inpatient rehabilitation, hospitals or facilities. And in terms of people changing their mind, I think we might want to consider that very vulnerable period when they're having transitions of care, because patients, it's not unusual for patients to change their mind when we're admitting them to an inpatient rehab hospital from some catastrophic event that happened that maybe initially they thought they were not going to survive or life would be terrible. And then they wind up coming over to rehab where we're talking about goals and getting them back to the community. So I think it's very, very important to reassess and have that conversation again when patients are transitioning from one level of care to another. And same with the families. Maybe somebody had a stroke and they were not able to speak for themselves at the acute care hospital, and then they're coming over to rehab, and we need to have that conversation again and talk about how we're gonna handle the situation and what the goals are going forward.
Great. Thank you for emphasizing the importance of updates at transitions. And those are really great comments, Alyssa. Thank you. Christine, you have your hand up. Is that a leftover or okay? Shabina.
I had my hand up. The thing is, this also recently happened a few months ago that I had a small procedure done, and it was not very like life-threatening or something. It was an outpatient procedure. And they asked me, if something happens. No, actually, she didn't ask me anything, and I'm the one who approached that person and said, "Hey, I want to put this on the system at Northwestern Hospital that if something happens to me, don't resuscitate me. I'm done." And she says, "This is not a big procedure. Why are you talking about this?" I said, "Reason why I'm talking about it is because of Battelle." And CMS, me and them are getting together all the time. And I want to make some awareness that I want you to document this. So if I did have something more serious procedure, if this is a smaller one, you have some documentation on file what I want. Something, I'm crossing my T's and I's. And she goes, "Don't talk about this." And I said, "No, I have to talk about it. I want this to be documented somehow because I know my children won't say anything and they don't know that much, and I don't have a legal document in file somewhere. I don't have a will, I don't have an attorney or trust or any of these documents out there. But I just want some sort of documentation. If you open up the Epic system, here it is." And she said, "Oh, it's not needed." And I said, "Really? I heard that it's needed, so why don't you just document it? But this is not very serious. You'll be fine." And I said, "Thank you for letting me know, but still." So my question, I'm piggybacking on the other question. If I had a triple bypass surgery, would it been taken more seriously and updated at that time at the Epic system in my chart or somewhere? Or do I really need to set aside a legal document with their attorney? And some people can't even afford attorneys and wills and things like that, or they don't even have that much to do, or they're not even educated to know and the awareness of it at all. So what do you do then?
Yeah.
In other words, did I cross my T's and I's just in case? Because now all of you guys are my witnesses that I did sign this document and I need to get this done.
Yeah, Shabina, you're getting some comments in the chat applauding you for your advocacy for yourself, and folks are highlighting the need for these conversations to be normalized and to do more education so that staff and providers are more aware of the need for these conversations. Janice.
Yes, I just really appreciate what everybody's sharing. And, I just want to reiterate the importance of portability because somebody mentioned that they can't be used in other states often. Other states won't accept it. And they were talking about an attorney now. And I know with my advanced care plans, they ask for 2 witnesses, and that's fine. And it's on record. And our kind of rule of thumb was, every 10 years is D's, divorce, decade, death of somebody. But mine's much longer than that, but the people still I know that we're on there, and so it'll still be honored. What I want to, because I'm still with the same health system too. So what I wanted to mention is years ago, I had a friend who was had advanced cancer, and she had just come out of the hospital and went into a rehab, and she fell right after she got there. They didn't really walk her to the bathroom, and she fell, and they put her right back in the hospital because she fell. She literally wasn't even there for an hour. Her family wasn't able to come, and I live right by the hospitals where I live. And so I just happened to contact her at the time when she was there, right? And she happened to be on, answered her phone. And I said, "Would you like me to come up?" So I went up. Well, the doctor, when he came in to see her, she was okay, but the nursing home or the rehab had to put her in there because she fell in the bathroom. Um, he left and he said she has her DNR advanced care planning here. Maybe, you'd like to go over it with her. So evidently, I don't know if her family hadn't done it, whatever. He literally left her record there. And so I was talking to her a little bit about it. She wanted she wanted to live no matter what, but her previous hospital visit, there was just her information there. And I said, your information is here. Would you like me to look it over? Which I did. And it noted that she had been in for sepsis, her previous hospitalization, and she wasn't even aware of it. And she was more concerned about that sepsis than her current state, which was, she didn't really live much longer and wanted all the extraordinary assistance to keep her alive. Which, when the doctor came back in, I mentioned she likes, she wants it to stay the same, and she mentioned about not knowing about her sepsis. So she actually was very cognitive and fully aware of what she wanted and understood the implications, of her decision. About a few weeks later, she changed it. So anyway, I'm just saying it is very complicated, as Lynn and many others have, called out. And I just want to add one other thing about health status. Have it changed at updated health status. Well, somebody could have diabetes and then they're diagnosed with hypertension. I don't know necessarily with every health status change, like I need cataract surgery or, or something, that is a reason for updating it unless there's really a different decision to be made. Thank you.
Thank you, Janice, for sharing that story with your friend, and thank you for being such a good friend, and for reminding us about the importance of portability and the perspective on updates as well. So thank you. Christine, your hand is up again. Did you mean to have
Yeah,
it up or okay?
I meant
Great.
to have it up this time.
Super.
So 2 really quick points, or maybe 1, because I just forgot what the other one was. My other point was on the advanced directives. I think even just in how these things will be carried out is important, right? In my advanced directives, I've donated my body to 2 different institutions. And like I said, I don't know where it's going, but I also got a letter from one of the institutions saying that my death has to occur within 150 miles. And so if I am outside of that 150 miles now, the radius, they will not come get me, right? And so I think when we think about these advanced directives and what the options we are giving people, like how does that play out if someone like me is traveling and I'm in DC for a meeting when something happens and then it's in my advanced directives, right? But I'm not within 150 miles of where this hospital would come take me. So how does that work? And the other point was this, that I put in the name of a documentary, a lot of people who got into car accidents or things that they did not expect, and other people were left in limbo trying to make a decision for them without ever having had a conversation, because these were healthy people who never thought about these things. So I think the importance of having this for everyone in general is just there. You never know what's going to happen. So
Thank
that's it.
Thank you, Christine. So I see two hands up. So we'll take those two hands, and then I want to turn it to CMS to see if they have any specific questions that have gone unanswered. So Mary Ellen.
Hi, good afternoon. Mary Ellen DeBartoleben with Encompass Health, and I appreciate all of these very relevant and meaningful perspectives. This is such an important part of the care continuum, and in post-acute care, like Dr. Charbonneau mentioned, some of these things can either need to be updated or revised, or actually put into effect, and having these discussions based on the care of the patient. I have some more logistical or specification-based comments. One relates to who will be eligible to complete this with the patient. Are there certain care providers that it will be limited to count towards this measure? And then as part of that, there is a advanced care planning discussion that is billable by physicians under Medicare, and that requires a 16-minute advanced care planning conversation, and whether that is being considered as part of the specifications for this measure, along the lines of, does it have to be a physician? Does it have to be 16 minutes? Or is there more flexibility with who can have this conversation, and is there a minimum length of time? Because those specifications are out there for that discussion, and is that relevant or involved in this measure, or is that separate? And then secondly, related to the measurement itself, and I know we've talked about trying to avoid process measures. If this is merely a box to be checked that this exists, and not any sort of electronic measure, which is not in post-acute care yet, will there be any requirement that this some sort of audit or review to ensure that there is documentation to support those checkboxes?
Thank you, Mary Ellen. Wanted to see if Dr. Klein wanted to weigh in on some of those detailed questions.
I don't think we have specific answers for that at this point in time. I do appreciate the comment, though, of aligning payment appropriately. And we'll go back and talk to, some of the folks who have made very specific requirements for that billing code.
Thanks, Dr. Schreiber.
Thank you. Carol.
Yeah, I want to go back to the original question of, if this is going to be implemented in hospitals, what kinds of things need to happen for it to be some variation of it to be implemented in post-acute care. And while I agree with everything we've discussed, and I strongly support ACP, I want to think about a couple things in terms of patient perspective for people who have not dealt with this. And I think one was written in the comments before this meeting about ACP fatigue. But a second one that's sort of related to that I have experienced in questions from patients many, many times is patients or their caregivers having never even heard about advanced care planning, and then suddenly exposed to it because of a hospitalization or because they've been in one or two settings where the comment comes up. What they're asking is there something going on with me that I don't know? Because nobody's asked them what they want on this issue, and then suddenly people are saying, well, if something happened or you couldn't breathe or, if your heart stopped. And so a lot of times they're suspicious, that what's happening. And so I think we really need to think about this with post-acute care because of the problem of documentation of ACP often not moving from one setting to another. That if a patient deals with this in the hospital, and there are lots of reasons why that information is not communicated to post-acute settings, but also it's not uncommon for patients to go from acute to one post-acute setting to another in home care, that there's that fatigue, but also that sense of why is suddenly everybody asking me about this, or I told somebody, why has nobody told you? And so in implementing in post-acute care, I think we also need to think about that whole issue of normalizing, like what will we learn from this being in the hospital that I think can inform how we address this in post-acute care so that it doesn't become burdensome to the patients, but also so it doesn't lead patients to think somebody's withholding information from them. And the other thing related to that, I've worked for the last 20 years with a population, including a lot of people who they themselves experienced, or they have heard family stories experiencing family members who were denied care for various reasons. I live in the South, and I have patients who remember Jim Crow. And so I think recognizing that for some people, any comment about advance directives, I've had patients say, is that because they don't want to treat me or they don't think I deserve this? And so, and I don't think that comes up when you have somebody going into surgery 2 hours, in the next 2 hours. But I think in the home, a lot of times those conversations are different and some of those patients' concerns come up. And so I think we need this, but I think part of normalizing it, and maybe we start with the fact that in a hospital, at least if you're 18 years old, you're asked this question, or anybody above the age of 18. But I think it all goes to normalizing the issue of creating advance directives and talking to loved ones about what we want, as well as talking to providers. So I really think the first step is, what do we do if this is introduced first in hospitals that normalizes the process and the topic in a way that as it's introduced into other settings, it doesn't feel as new or potentially as threatening as it may to some patients otherwise.
Great
That's
comment.
great points.
Yeah, I wanted to turn it back to CMS because I think we've been discussing this for a bit of time now, and we're starting to, I think, hear some similar comments coming through in the chat. So just wanted to see, Dr. Schreiber and others at CMS, are there other specific questions you wanted this group to weigh in on, or do you feel like we've sort of reached saturation?
Can I just ask a question, because I'm looking at Katie Balistraci on the screen. Katie, did you have your hand up? Because Katie's one of our measure developers, and I didn't know if she had any specifics.
I did, Michelle. Thank you so much. And I don't want to take too much time. I first want to say, hi, Katie Balistraci. I'm one of the measure developers from Yale Core. And this has been such a fabulous opportunity for me to listen to this discussion, so thoughtful and detailed. I want to take a minute, if I could, to address Mary Ellen's question, and echoing Dr. Schreiber, there are pieces of your question around billing, et cetera, that we really can't answer at this time. But the measure developer and working with CMS did really try in creating an ECQM and using clinical data from an EHR, tried to create a measure that really understood that there are many providers and many different types of providers in a hospital setting, and no doubt in other care settings, that are valuable in these ACP discussions with patients. And no doubt, as Dr. Schreiber noted, there's likely more work to do in that area, and because we're not lost on the fact that, right, oftentimes discussions need to be billed in some way, and there are limitations on billing. But it's such an important point, and I just wanted to note that in this version 1, as Dr. Klein noted in the comments, we really tried to address that, and no doubt as we continue to support CMS in this really important area, would love to see our ability to grow that kind of opportunity in the measure. Thank you, Dr. Schreiber. I hope that was okay.
Thanks. So Meredith, to your point, as I know we're trying to wrap up these conversations, first of all, this has been an extraordinary conversation and really an extraordinary opportunity to really dive so deeply in this topic that everybody, has strong feelings about. I want to particularly thank the committee for sharing very personal stories, because that is not always easy to do. And really, just with deep respect to everybody who kind of opened their hearts in talking about some of their personal experiences here. This is clearly a topic that I think people are very supportive of. I will tell you that there's chat going back and forth, even amongst CMS, about, okay, so how do we operationalize this now? I know that's a question that a few of you have raised, and that's something we will be thinking of, because this is unlikely to be, at least for a while, an electronic clinical quality measure in post-acute care. But I will announce, because, I think people are aware of this, that the first assessment instrument to be FHIR-based will be introduced this year in inpatient psychiatry. It has been worked on for a number of years, so I think that, digital capabilities are coming to other settings that aren't used to having electronic medical records, and there may be alternative ways of implementing some of these things that we're all very excited about. Again, I just want to take the opportunity to say thank you. Thank you for your very heartfelt comments, and thank you for helping guide CMS's decision-making going forward.
Great. So we're just going to skip to some next steps to just review what happens after today for all of you. Please, we will be sending you a feedback survey. If you wouldn't mind taking some time to complete that, we'd really appreciate it. And I will turn it over to Kate Buchanan.
Meredith, thank you all so much. It is the end of the day, and for us on the East Coast, and we're incredibly appreciative of all of this rich discussion and discourse. So thank you for that. And I'm going to go over some of our next steps. So although there were not votes up for the PAC LTC setting this cycle, there will be votes for hospital and clinician. You are, of course, welcome to comment on them. We'll be posting the recommendations on our website on January 30th. We will then be moving to a second public comment from February 2nd to the 16th. Although the comments will not impact the voting outcome, they are incredibly rich data pieces for CMS as they continue on in their rulemaking process. So we do take them seriously and we do pass them on. We will be posting the summary and the recording of this meeting by February 12th. So in case you would like to go back and listen in on some of the discussion, or if there's something you thought you heard, wanted clarification on, or if you want to share with others that you think this conversation will be really important for them to know, we will be sharing both a written meeting summary as well as the recording. After that, we will post the final recommendations report on our website on February 25th. So I am again extending great gratitude, and Janice, I see your hand is raised.
Yes, I went in to read the public comments when this had first come, when you first posted it, and I was really surprised at how many comments there was. And so when you send out the summary, is it an amalgam of all the three committees, or is it separate for each one, or just curious about that?
Yeah, so the summary will be mostly focused on the discourse today. So that's what we're going to focus on. Some of it you'll see will be represented in the written comments as well as the verbal comments we received, but those are a resource on our website. This will be focusing on more on the discourse that we had today.
Thank you.
Thank you. And so extending immense gratitude towards our committee, our co-chairs, CMS, and the developer. I want to hand it over to Dr. Schreiber to close us out with some final comments.
You're giving me the final word, Kate?
I am, yes.
I'm very impressed. Some of you have been doing this now for 3 days with us. Those of you who haven't, I will tell you this is the end of 3 days of sessions between the hospital committee, the clinician committee, the post-acute care committee, and our special roundtable. So I'm just going to wrap up in reflection of 3 days in addition to this committee. It has been an extraordinary 3 days with really a great opportunity for discussion. We have appreciated everybody's input and comments. And again, CMS takes your comments very seriously. It helps us in crafting appropriate policy that really is reflective of stakeholder feedback. To Battelle, 3 days has been a very long time. And if you are anywhere as exhausted as I am, I'm sympathetic. So thank you. This has been an extraordinary amount of work, and you guys have really been wonderful. To everyone from CMS on the line, our measure developer, our measure stewards, others, and our contractors, thank you again. It really does take a village to put all of this together. There's a lot of work behind the scenes. I particularly want to call out Mel Gross from CMS, who's been our coordinator working with Battelle in really making this happen. So Mel, a personal note of thanks and appreciation. With that, I just want to again say thank you so much to the committee. I thought this particular conversation was so heartfelt and so deeply thought, and again, sharing of very personal stories, that it was an extraordinary meeting. And to each and every one of you, thank you so very much. And we really learned a lot from the conversation. So Kate, I actually will turn it back to you guys to see formal goodbyes, but on behalf of CMS, thank you to all of you.
Thank you all so much. We appreciate it. Have a good rest of your day and week.
Great. Take care, everyone. Thank you so much.
Thanks for always hearing us.
Thanks, Christine. Take care.